On behalf of Centers for Medicare and Medicaid Services, CMS Division of Tribal Affairs, in collaboration with CMS Centers for Medicare, I'd like to welcome everyone to the All Tribes webinar today. My name is Michaela Holm. I work with Kaufman and Associates, and I'll be your moderator. Today's webinar is titled CY 2024 Medicare Hospital Outpatient Prospective Payment System 1786P and Physician's Fee Schedule 1784P Proposed Rules. Before we begin, I'd like to go over some of your Zoom webinar interfaces. First, the presentation slide will appear in the main window, while the speaker will appear in the top corner. At the bottom of your screen in the menu bar, here is where you'll find the chat, raise hand, Q&A, and closed caption functions. Please use the chat box to report any technical issues you're experiencing, and we'll respond to these concerns as they come in. Next to the chat box is the raise hand feature. You're able to use this during our Q&A segment to let us know when you'd like us to unmute your mic so you can ask a question out loud. Another way, you're able to submit a question in the Q&A box itself, where you can leave your question at any point during the webinar for the presenters to address during the Q&A segment at the end. Lastly, live captioning is available for today's broadcast. Simply click the CC icon to use this feature. Please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. This webinar series is supported by an award by Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or Center for Medicare and Medicaid Services. And at this time, I'd like to welcome everyone to today's webinar, and I'll pass it over to Beverly Lofton.
Thank you, Michaela, for that introduction. Well, good afternoon. I'm Beverly Lofton, and I am a Senior Policy Advisor in the Division of Tribal Affairs here at CMS. This webinar is in collaboration with the Division of Tribal Affairs, the CMS Center for Medicare, the CMS Center for Medicare and Medicaid Innovation, and the CMS Federal Coordinated Healthcare Office. During this webinar, our presenters will provide an overview of the proposed rules in the outpatient prospective payment system and physician fee schedule, specifically proposed changes that may be of interest to IHS and tribal health facilities. Presenters will also provide an overview of the Medicare Diabetes Program and is seeking feedback on the Medicaid Diabetes Strategy. Please note that written comments for both proposed rules may be submitted to the Federal Register by September 11, 2023. Any materials related to this presentation can be downloaded from our spotlight page of the CMS American Indian and Alaska Native Outreach and Education website. That website can be found at go.cms.gov/AIAN. The web link will be added to the chat. We are pleased to be joined on this webinar by Josh McFeeters and Christopher Corwin from the Center for Medicare, Tina Coley from the Center from Medicare and Medicaid Innovation, and Dr. Mayer from the Federal Coordinated Healthcare Office. So I will now begin to hand this over to Josh so he can begin the presentation today. Thank you, Josh.
Beverly. Thank you, Beverly. So I'll discuss a couple of proposals, one proposal and one comment solicitation in the proposed 2024 Medicare Hospital Outpatient Prospective Payment System Rule. The proposal is for REHs that are either IHS affiliated or tribal affiliated, or facilities that could become REHs. Currently, this REH program, this Rural Emergency Hospitals, was developed in the past year and is a way to have hospitals that maybe can no longer support inpatient services to be able to provide care in their area, at least outpatient care, and their incentive payments to help hospitals get facilities convert over to providing rural emergency services under this program. Now, one of the issues that some IHS and tribal providers that would otherwise qualify as an RH is, it says that they did not like the payment option where services are paid individually with an incentive payment. And instead, they want to retain the all-inclusive rate or AIR for even though they might convert to an REH. So this proposal in the OPPS proposed rule would allow tribal and IHS facilities that would otherwise qualify to become an REH to retain the AIR when they convert to an REH for payment for system for their services that they provide. So that is the one proposal in the OPPS. The other topic is a comment solicitation. There are, while hospital IHS and travel facilities are paid for outpatient services under the outpatient all-inclusive rate, there are a few specialized facilities that have some very expensive services. For example, they may provide oncology services, and they have drugs that are may cost thousands or tens of thousands of dollars, and the all-inclusive rate, which pays somewhere in the range of $600 to $800, depending on where you locate it in the United States, may not be a sufficient payment for some of these services. So a comment solicitation is in the OPPS rule. Look at ways to address this issue in terms of maybe which drugs to be possibly be paid for or other services. Let's see, some other things. Should there possibly be outlier payments? Should it be a cost threshold for drugs, or maybe a sort of a formulary or a list of drugs that would qualify? These are suggested topics for discussion. We encourage providers and other stakeholders to submit comments that based on this comment solicitation within the rule, so that it'll help develop policy going forward in the future. That's what I have. So I'll turn it back to Beverly.
Thank you so much. And we will now hand it over to Chris.
Thanks, Beverly. Good afternoon, good afternoon to all of those on the webinar. I'm excited to present to you today. My name is Chris Corwin. I am a health insurance specialist with the Division of Practitioner Services, and I staff the updates to the physician fee schedule. And next slide, please. And this slide is just a disclaimer. Of course, I encourage all here to review the rule, which is now publicly posted, but information that we present today is only intended to be a general summary. So if you have specific questions, I encourage you to submit comments, but you can also review the publicly posted rule that's available. Next slide, please. And so on this first slide, we just lay out the timelines. The content that I'm discussing today is applicable to payment in 2024. That's a key. In terms of those of you who are considering submitting comments, we hope that you do. And if you choose to do so, earlier is encouraged, but you have until September 11, 2023 to submit a comment. And the link is here in the presentation, and it should be easily available through your chosen search engine if you'd like to peruse the rule. Next slide, please. So let me give a general overview of telehealth. And for those of you not familiar with Medicare Telehealth, we use the term Medicare Telehealth services. It means something very specific to the pay for under Medicare Part B. The industry as a whole, and the space as a whole, uses somewhat broader or different terms. But when we speak of Medicare telehealth services, I'm speaking particularly to services that are separately payable under Part B. So with that level setting, there are 265 services that are available on our telehealth services list. And again, you can find that list online, but we are adding 2 specific services this year, and we've removed no service from the list in comparison to last year. So in terms of enhancing access and maintaining access to these services, we are hopeful and encouraged by what Congress did this last year, which is implemented the Consolidated Appropriations Act of 2023. And so at the bottom of the slide, you can see some of the provisions of the Consolidated Appropriations Act of 2023, but we heard in public comment last year some concerns from the public about the continued availability of services that were available only temporarily on the list. And so what this means in effect is that the telehealth services that are available today will be available for calendar year 2024. And just to briefly highlight why the flexibilities were flexibilities during the PHE, as a point of context, the Medicare Telehealth statute has specific provisions that limit distant site practitioners and limits originating sites. And during the PHE, we expanded each of those. And so as you can see at the bottom of the slide before you, we're going to continue an expanded definition of telehealth practitioners for calendar year 2024, which includes those listed there, but I'll just read them off briefly in case some are audio only on this call. Occupational therapists, qualified physical therapists, qualified speech language pathologists, and qualified audiologists. And that's in addition to the statutory practitioners, which included qualifying health practitioners, both non-physician and physician practitioners. And again, to the almost the second from the bottom dot point on this slide, previously, specifically for furnishing behavioral health telehealth services, there was an in-person requirement, meaning that prior to an initial telehealth behavioral health service, the beneficiary receiving the service must have an in-person visit with the practice or practitioner, and then subsequent visits, once there was an established patient relationship for telehealth to behavioral health, subsequent visits had to occur at least every 12 months in person. That's been delayed. And so for calendar year 2024, again, as it stands now, as our general policy, the behavioral health telehealth services that are being furnished now in absence of an in-person visit remain applicable. And then in terms of the list, as I referenced before, and this is the last dot point on the slide, we have a set of services that are permanently on the list, and then a subset of services that have temporary status. I encourage those of you interested to go to our rule and read the preamble, because we've proposed a simplification, and we're proposing that simplification for a few reasons. But first, it keeps intact the existing longstanding requirements for supporting evidence. But we also believe that this proposal that we're seeking comment on will also reduce burden for submitters, while also reducing confusion. Because during the PHE, some services were added to the list on a sub-regulatory basis between rulemaking cycles, and those were enabled by PHE waivers. Because we no longer have PHE waivers, that is, the public health emergency has ended, and we no longer have those waivers available, CMS proposes to keep available certain temporary services as provisional to allow evidence generation to continue. And we're proposing that any permanent or previously termed category 1 or 2 services would receive a simplified permanent status. And again, this will allow us to simplify a bit and explain how the complexity of the various waivers and how we wound down the PHE waivers in light of congressional activity and when they passed the CA 2023. So that brings me to the next topic. Next slide, please. Next slide, please. Thank you. And so this is another clarification, and we're requesting comment in this year's proposed rule. We have certain provisions that pertain to virtual direct supervision, and so as a general matter, virtual direct supervision remains as we described in last year's rule. We're going to propose to continue to define direct supervision to permit the presence of immediate availability of the supervising practitioner through real-time audio and visual interactive telecommunications through December 31st, 2024. And we believe that extending this definition of direct supervision through December 31st, 2024 would align with the time frame of this policy and many of the other previously discussed CDC telehealth policies that were extended under the provisions of the CA 2023. And particularly for telehealth services that are furnished in a teaching setting, we're proposing to allow teaching physicians to have a virtual presence via audio, video, real-time communications technology when the resident furnishes telehealth services, and that applies both within and outside metropolitan statistical areas. So if the residency location, training location, it doesn't matter if it's inside or outside the MSA, virtual supervision still applies. And so as part of what happened at the wind down of the PHE this year, we announced that we were exercising enforcement discretion to allow for this policy in all residency sites. And so I just wanted to highlight that that will carry forward through 2024. Next slide, please. And that concludes my portion of the presentation, and I think I'll hand it back over to Beverly. Or maybe if there's questions in the chat, we can take those questions now.
And we can actually save the questions till the end, if that's okay, Chris.
Sure.
Okay.
Yeah.
Yes. Okay. Thank you so much, Chris. So now I'll hand it over to Tina.
Good afternoon. My name is Tina Cooley. I am a member of the Medicare Diabetes Prevention Program team, and I'm very appreciative of this opportunity to share our proposed changes to the MDPP program in the upcoming 2024 physician fee schedule proposed rule. And since we're in active rulemaking process, we will be in listening mode and really value your input, and we look forward to hearing from you during this comment phase. Next slide. So CMS is working to make some enhancements to MDPP to improve equity and access to the program, including among American Indian, Alaskan Natives, and tribal groups. As we consider updates to the program, we strive to improve equity across the program, increase the number of participating suppliers and their capacity to offer diabetes prevention services, as well as increase the number of individuals who not only enroll in the program, but also complete MDPP. Next slide. So MDPP is established, updated, and terminated through rulemaking. And when we learned that the public health emergency was ending on May 11th, we worked to find a way to extend the flexibilities which allowed for virtual delivery of MDPP during the pandemic, including the virtual weight collection. On May 2nd, 2023, CMS published a notice on the Federal Register to extend the PHE flexibilities through the end of the year. And this provided us time to consider rulemaking to extend those flexibilities beyond 2023, while allowing virtual delivery to continue through December 31st. Next slide. On July 13th, CMS announced its proposed policies in the 2024 physician fee schedule. This included some exciting proposed updates to MDPP, which include extending the PHE flexibilities for 4 years until December 31st, 2027, retiring ongoing maintenance services, and streamlining the MDPP payment schedule. Next slide. The first proposed policy I'm going to discuss is the one to extend the PHE flexibilities for 4 years. Note that in the original rule, MDPP participants could participate in a handful of virtual makeup sessions. For the next 4 years, we are eliminating the maximum number of virtual sessions, meaning that participants can receive MDPP in a manner consistent with CDC's definition of distance learning sessions. We're also proposing to allow suppliers to use alternatives to the requirements for in-person weight measurement. This means that suppliers can collect weights virtually through digital technology or self-reported weight measurement from an at-home digital scale. We're also proposing to retire the ongoing maintenance services starting in 2024. And if you recall, MDPP was originally a 2-year program, with ongoing maintenance services being delivered in months 13 through 24 for participants who maintain the 5% weight loss. In the calendar year 2022 PFS, we removed that eligibility for ongoing maintenance services for those who started the program in 2022 or later. So what this means is that eligibility for ongoing maintenance services ends on December 31st, 2023 for all Medicare beneficiaries. Next slide. We've heard from you that the MDPP payment schedule is complicated and confusing. An example of this is that currently the payment schedule has 16 G codes for MDPP. In response, we're proposing to streamline the payment schedule, which will include only 6 G codes. We are eliminating the 11 G codes related to attendance and replacing them with 2 new ones. And we're proposing to allow for suppliers to be paid on a fee-for-service basis for attendance. This means that we're allowing for up to 22 sessions to be paid in a 12-month period. To better track whether a participant attended the MDPP session in person or through distance learning, we've created 2 new G codes, one for in-person attendance and one for distance learning. In terms of performance payments, we're proposing to continue to pay for diabetes risk reduction in the streamlined payment schedule. This means that we'll continue to provide a one-time payment for a participant reaching the 5 and 9% weight goals, and these G codes are staying the same. We're also still paying for maintenance of the 5% weight loss goal in months 7 through 12, and have created a new G code for the maintenance of weight loss. Next slide. We want to make sure you are aware of some other proposed policies in the 2024 PFS proposed rule that are relevant to diabetes. For an example, CMS is proposing to expand diabetes screening and diabetes definitions. As part of the diabetes screening, CMS is proposing to add hemoglobin A1C to the tests included in this benefit. There's also a proposal to expand and simplify the frequency limitations for diabetes screening and to simplify the regulatory definition of diabetes for diabetes screening. For more information on the proposed policies, please refer to the link that's on this slide to the Federal Register. We encourage you to submit public comments on the proposed changes, MDPP and otherwise diabetes related, whether they're positive, negative, or anything in between. And you can do this by going to regulations.gov. And in your comment, please refer to the file code CMS-1784-P. Last slide. So we want to hear from you as we consider how to improve the Medicare diabetes prevention program. We greatly appreciate and value all of your comments. As you well know, the best way to prevent and mitigate diabetes burden among tribal populations is through screening and referral to appropriate programs like the diabetes prevention programs. We would also very much like to establish regular listening sessions and continue with tribal consultation. And we will strive to better communicate our progress on MDPP with you and to be a partner in diabetes prevention in your communities. And with that, I thank you all for your time.
Thank you so much, Tina. I do see that we have some questions in the Q&A chat, but we're going to hold those questions to the end. And now we're going to move on to Dr. Mayer. So Dr. Mayer, you're up, and we are looking for feedback from Dr. Mayer's presentation, but he'll give you more on that. Go ahead.
Thank you very much, Beverly, and hello, everyone. And it is a pleasure to be with you today, and I appreciate your time and look forward to your feedback on what we're doing with respect to our CMS-wide and Medicaid-specific diabetes strategy. I am a physician with the Federal Coordinated Healthcare Office, and I'm working with representatives from across CMS to attempt to come up with an agency-wide coordinated strategy to reduce the burden of illness from diabetes. And obviously, we have significant interest in being able to enable improvements in reducing the burden of illness among the American Indian and Alaska Native communities. So our purpose today is to get your input on how to pursue an effective strategy to assist and collaborate with you on reducing the burden of illness from diabetes, specifically among Medicaid beneficiaries. But also there may be other ways that we could collaborate with you, and we're well aware of the very successful program that the Indian Health Service has, the special program on diabetes, and look forward to hearing your thoughts about how we might better coordinate our efforts with that program. I wanted to just mention a little bit of a background on how we got to where we are with coming up with this strategy. We recognize, the administrator of CMS has recognized roughly a year and a half ago, the critical importance of and burden of illness from diabetes among the people that we serve, and the clear need to better address the issues there and reduce the burden of illness there, and the opportunity to do that across the agency using all the resources at our disposal, including our partners and other stakeholders. So a work group was established to address this issue, and that group began working, as I said, a year and a half or so ago. Some of you may know that in September of last year, there was a White House conference on hunger, nutrition, and health. And that conference also addressed the important issue of diabetes, specifically type 2 diabetes. And what we're trying to do collectively as an agency is to contribute to the challenge that the White House has given us to end hunger and build healthier communities. And it's in that context that we come to you for a discussion today. As some of you may know, we did meet with you for a listening session at the All Tribes webinar in May of this year, May 31st. Also, we requested input in advance of that meeting, that webinar, from the Tribal Leader Diabetes Committee. And more recently, in July 26th, we met with the Tribal Technical Advisory Group in Washington, D.C. at the Museum, National Museum of the American Indian, and received some very helpful input and feedback there, and look forward to continuing those discussions today and beyond. So if you'll go to the next slide, please. What we'd like to cover today is just a little bit about the strategy development process that we're using, to talk about how this process was applied to Medicare and the interventions that now are being implemented with respect to Medicare to reduce the burden of illness among those enrollees, to talk a little bit about the challenges and opportunities that we have in Medicaid, and then to pose a few questions to you to help stimulate discussion. And as was mentioned earlier, for the other presentations, there's specific rulemaking going on, and in those cases, we have to work through those processes for getting comments and input. But we are not talking about that with respect to the Medicaid strategy today. So we have more of an opportunity to discuss what you see as needs and opportunities. So if you go to the next slide, please. We have as an aspirational goal for our strategy that 100% of people that we serve should receive evidence-based diabetes screening, prevention, and treatment services across the lifespan. And we intend to address this for all who are eligible and enrolled. So looking beyond just those that are currently enrolled, but to assure that everybody who could potentially be enrolled in CMS programs, that we should address them as well in our strategy. Certainly, we are looking to address American Indian and Alaska Native entities, our 50 states, the District of Columbia and territories, and the various populations that you see here, from children to pregnant women and the underserved, and all the programs that we operate through CMS, Medicare, Medicaid, and CHIP, and the marketplace. And we've talked about the consultative opportunities to date, so I'll move on from there. If you'll go to the next slide, please. So I mentioned that we have gone through this process for our Medicare diabetes strategy. And through that process, we have come up with a 10-part plan to reduce the burden of illness from diabetes. And I won't go through each of these, but we'll just point out that we're talking about, as has already been mentioned by Tina, the increasing diabetes screening, which today is less than 5% of people who are eligible for diabetes screening, improving intensive behavioral therapy for obesity, and the accessibility of that therapy and the use and receipt of that therapy through the diabetes prevention program, as well as addressing issues of out-of-pocket costs for diabetes related services, including medications, expanding community outreach, and that's part of the current proposed rule that we have for the 2024 physician fee schedule. We're looking to enhance support for health-related social needs and improve our measurement, promotion, and reward of enrollees, as well as providers and plans for addressing the needs of and assuring the receipt of services that we know to be evidence-based in reducing the burden of illness from diabetes, and in particular for underserved populations. So that kind of comprehensive approach that is a systems-based approach and addresses a multitude of barriers to receipt of diabetes services in the Medicare population is the type of approach we're looking to apply to Medicaid enrollees. If you go to the next slide, please. We know that there's been some success with the Indian Health Service programs related to diabetes. And this is a chart that speaks to the prevalence of diabetes over time from 2006 to 2017. And you can see that there's been some improvement since 2013 in the prevalence of diabetes among adults that are seen for their care at the Indian Health Service. So there's been some some significant impact there of the work that you all are currently doing, and that's going on in folks in the American Indian and Alaska Native communities. If you go to the next slide, please. But there are many challenges that remain. And again, I won't go through all of these, but I'll touch on some of them. That American Indian and Alaska Native adults have a rate of prevalence of diabetes that's almost 3 times higher than non-Hispanic white adults. In Medicare Advantage, American Indian and Alaska Native people are 2 times more likely to have poor control of blood sugar than white people. 2.3 times more likely to die from diabetes than non-Hispanic white people, and 2 times more likely to be diagnosed with end-stage kidney disease, which is a complication of type 2 diabetes. And as a key risk factor for developing type 2 diabetes, American Indian and Alaska Native adults are 60% more likely to have obesity than non-Hispanic white adults. So we have challenges and opportunities, as I know you are well aware, that are particularly relevant in Alaska Native and American Indian populations. If you go to the next slide, please. So we have, for purposes of today's discussion, a few questions we thought we would pose to you to stimulate discussion. And this is by no means intended to limit what it is that you wish to share with us. But we thought that perhaps you might be able to comment on what are the opportunities that we have for improving receipt of diabetes services among American Indian and Alaska Native people eligible for Medicaid and CHIP. That you might be able to help shed some light on what you see as the key barriers for being successful in improving the receipt of prevention and treatment services for diabetes. And we'd like to hear from you your thoughts about what additional considerations we should be addressing in a strategy to improve diabetes equity in prevention and treatment. And then finally, wondering how American Indian and Alaska Native entities and CMS might better collaborate to reduce the burden of illness from diabetes. So with that, I know we're going to be holding questions to the end, but I want to thank you again for your time and look forward to your insights. And I'll turn it back to you, Beverly, after just mentioning here that with the benefit of the input today, we will not only summarize the discussion and follow up on any recommendations that you may give to us, and continue our listening with you all and communicating progress on our strategy. Also, we welcome your input after today's meeting through the Tribal Affairs email or directly to me at the email address that you see on the slide in front of you. And now back to Beverly. Thank you.
Thank you so much, Dr. Mayer. Okay, so now what we'll do is, the flow we will do, this going to make sense, is we'll take questions. So we'll go into the Q&A session, take questions, and then I'm going to, right now, I'll hand it over to Michaela so that she can go over how you can present your questions if you want to turn your mic on, or if you're just going to do the read those questions off and answer those questions. So we'll do that first. Then after that, we're going to go back to seeing if you all had feedback on Dr. Mayer's presentation, because it's very important that he can get some feedback on that. So hopefully you all jotted down some feedback that you can provide to him. Go ahead, Michaela. Thank you.
Thank you, Beverly. So we have 2 questions in the Q&A box. The first question that I'm going to read off is, thank you, Josh. So on the second item, you are soliciting feedback on if this is an issue for us or not, right?
Oh, here. Yes, what it is, it's sort of following up from an earlier question that Melissa sent. She's asking about the sort of for the providers that have specialty sort of high cost drugs, This is a comment solicitation in the rule. This is not a policy. We're looking for help from stakeholders, interested parties, the public. There are a series of questions that can help guide the discussion. We're not limiting it to that, but it's to help drive it. But it's in the rule. Please, you can go to the rule and you can see the basis of the comment solicitation and the areas that we're interested to get feedback on, and we'll take it from there.
Great, thank you. And then the next question that we have is the telehealth provisions that will be extended. For example, the originating site visit, are those being proposed to made permanent or just CY 2024?
Great question. Thank you for the question, Melissa. Allow me to clarify. There's a few parts to the extension. In the temporary expansion of eligible sites, which includes the patient's home, there's a little bit of nuance here that I really want to be careful with. Specifically for behavioral health telehealth services, the home as an eligible originating site extends past the CAA 2023 provisions. However, for purposes of the home as an eligible originating site, that flexibility, and Congress was clear on this, ends for non-behavioral health services at the end of calendar year 2024. And further, for the expanded list of eligible telehealth practitioners, when I the slide that mentions OTs, PTs, speech language pathologists, and audiologists, after 2024, in the absence of further legislation, they would no longer be practitioners under the Medicare Telehealth statute. So those two are statutory. And then there's one other wrinkle, and forgive me because I forgot to mention it in the presentation, but the CAA 2023 also adds two types of practitioners that are eligible for furnished telehealth service, and that's marriage and family therapists and mental health counselors. And again, those would be permanent as well, we expect. Melissa, I want to make sure, I didn't want to go too long, but maybe just a thumbs up or clarify that I did address your question in full. She's on.
Thank you, Christopher. And so if anybody has any additional questions.
Can you hear me?
Yes.
I can, yes. I just wanted to make sure that I
was
addressed.
trying to type because I didn't know if I could talk. Melissa Gower here, Chickasaw Nation. Thank you for that answer. It did clarify. The non-behavioral health one is the one that we've been advocating for continues. We're in the Oklahoma, really close to Texas, and we serve so many patients out of the state of Texas, and that's just been really extremely helpful, especially for our elderly patients. So as I understand what you said, that does not continue.
Again, in absence of further legislation, that's correct.
Okay, thank you.
Hey, thank you. If anyone else has any additional questions, you can place them in the Q&A box located at the bottom of your screen, or you can use the raise hand function and we can unmute your line as well.
Yeah, can you hear me? It's Jim Roberts with ANTHC. Can I get a sound
Yes,
check?
hi, Jim. We can hear you.
Okay. All right, thank you. I think my question will be for Josh, but just to kind of recap the rule, we're happy and excited to see the proposed rule is seeking comment on payment for high-cost drugs for IHS and tribal pharmacies. Currently tribal operated hospitals are not sufficiently reimbursed by Medicare for these high-cost drugs, and we're concerned that the inability to be adequately reimbursed would affect our ability to be able to continue to drugs. So we struggle that you guys are seeking payments under the all-inclusive rate to make sure that they're adequate for high-cost drugs. And we share the concern that you're also concerned about the potential that this threatens the viability of IHS programs to be able to sustain and provide these types of drugs and services. So thank you for that. My question, Josh, is kind of on the timeline process for how you see this kind of rule or aspect of the rule developing. So, there was a similar process with the Medicare dish payments some years ago that took a couple of iterations of the outpatient prospective payment, or the IPPS rule at the time, to kind of finalize the outcome or the resolution on that issue. So how do you anticipate kind of you all making a decision through the administrative rulemaking process to get to the endpoint of where you guys would be able to share your information? And I asked the question because this is quite a complicated issue. And I think if you look at the questions, the 6 or 7 questions that you pose in the proposed rule, it's going to take some time and consensus to develop a response on behalf of the tribal system for that. So I guess I'm kind of interested to hear what you all might be thinking about how you would kind of make a decision on that process. Thank you.
Well, Tim, thank you for your comments, and thank you for reading the comments solicitation. Unfortunately, I can't really provide a timetable. I can't hold any commitments here. All we can say is that we're soliciting for comment, and definitely submit your comments to in time by September 11th, and that'll be an ongoing process. But unfortunately, I cannot provide any timeline or any guidance on when there might be an actual policy proposal to comment on at this point. Right now, it's just comments, and we're going to take the feedback and go from there.
Okay, thank you for that.
Sure.
If there are any other questions at this time, you can raise your hand and we can unmute your line, or you can type a question in the Q&A box located at the bottom of your screen.
Michaela, just to clarify, are we talking about questions related to the first presentations that are proposals out for comment, or are we talking also about the presentation on the Medicaid strategy at this point?
We are going over the questions from the first presentations, but since no other questions are coming through, I do see we have one more hand raised, then we can move to the other questions. And so Elliot, you should be unmuted at this time.
Oh, thank you very much, Michaela, Ms. Holm. I guess this is, my name is Elliot Mulholland. I'd like to also kind of echo what Jim Roberts just said about welcoming the solicitation for comments on a separate payment system for high-cost oncology drugs in the OPPS rule. That's something that we will be actively commenting on, and I had kind of a bit of an exchange there with Mr. McFeeters there in the chat box. But my question was specifically about the outlier payment request, which comes kind of at the tail end of the request for proposals. And my question there is CMS asking whether the kind of regular outlier payment system that's set out currently in the regs would be appropriate, or are you talking about maybe creating would it be appropriate to create a new outlier payment system under your authority under the statute to make outlier payments? That wasn't clear from the solicitation.
Yeah, fortunately, because the rule is out right now, I can't really speak anything beyond what is written in the rule in terms of that particular idea. Again, this is solicitation, that it's not, it's sort of guide, help you provide some comments and discuss, but it isn't intended to limit in any way, but I can't characterize it beyond what is in the rule.
Okay, understood. We'll certainly submit comments then that are broad enough to address those issues. Thank you very much again for including that in rule and for providing the summary today.
Okay, certainly.
Thank you, everyone, for those questions. That's always very helpful to get questions from the audience. So now let's move on to getting some feedback for Dr. Mayer on the diabetes strategy for Medicaid. So let's go to that. Dr. Mayer, did you want to say some more about it? Did you want to have some more feedback on it yourself first? And you're on mute. You're on mute, Dr. Mayer.
Of course I am. Thank you. I'd just like to maybe leave it open to folks to comment based on these questions or any other issues you might want to address. I also would ask that I think it's often very instructive for us to hear about personal experiences with the prevention, with screening, and with management of diabetes that you or your family members or your communities may have experienced, because sometimes we can gain tremendous insight from that into both the challenges and opportunities. So please feel free, to the extent you're comfortable, to share those experiences as well. We welcome hearing from you.
Thank you. And Michaela, can you also remind the audience how they can ask the question if they want to raise their hand or if they want to type it in the chat or in the Q&A?
Absolutely. Yeah, so if you have any feedback or have any questions, please use the raise hand function at the bottom of your screen and we can unmute your line. Otherwise, you can place something into the Q&A box as well. And so I do see that we have Jim Roberts has their hand raised. If we could unmute Jim. Jim, you should be able to speak now.
Okay, thank you. And Dr. Mayer, thank you for being here again. It was good to see you at the TTAG meeting a couple of weeks ago and appreciate your work on diabetes. And as your slides indicated and revealed, this is a big problem continuing for our people and in our health systems. I think in terms of opportunities, I think building on the success of the special diabetes programs for Indians and their ability to be able to be reimbursed as a provider type of some sort in the Medicaid and even Medicare program. I think the challenge for the Medicare diabetes prevention program was that you had to become a CDC approved or certified program. And many of the SDPI programs were implementing some of the CDC requirements already. They had not obtained that certification, but their standards of care were equivalent or exceeded some of the ADA standards of care and even the CDC requirements. So on one hand, you have programs in the tribal system that weren't able to participate and bill in the Medicare program because they weren't certified or approved by CDC. And that approval process is some on this call might be able to attest to, takes a significant amount of time. It's an administrative burden. And, in light of the fact that some of the standards of care that these programs had in place, it didn't make sense to be able to have to go through that process. So I think putting in place administrative burdens that would kind of prohibit our ability to participate in Medicaid and Medicare reimbursements in that process and build on the SDPI programs, I think would be an excellent opportunity. So I think let's take a lesson learned from the Medicare process and let's not repeat that in at least Medicaid, but build on that. So that's all I had. Thank you.
Jim, I wonder if I might ask a further question to get a little better understanding. Certainly we have heard about in feedback from folks about the time and administrative and standards requirements of the CDC accreditation process. Are there specific areas that you could maybe suggest that we focus our attention on there? I mean, certainly we can dig into that and talk with folks further offline, but are there any high level focus areas you think we ought to be thinking about to address those barriers?
Not that come to mind immediately, and just to kind of go back and explain further my recommendation about building on the SDPI programs. In some instances, those programs might be disconnected from the health facilities. So they're still part of the healthcare makeup, but they may not actually be within the four walls of our clinics and hospitals. But they interact and associate very closely with our medical professionals. They might have registered dietitians in that meet some of the provider qualifications for being able to bill some of these prevention activities. But because they're not explicitly linked into the facility, there might be some limitations on their ability to bill. And therefore that would be, that might limit their ability to provide some of the services and things that you all might be looking at. So I think trying to link and couple together those programs with the health providers, I think would be an important process and step in order for us to participate in some of the things that you all are working on. Thank you.
Thank you, Jim. I think Tina has, do you have anything you want to add to that, Tina? I just saw you had something in the chat.
Yeah, no, I just thank you. Any feedback I think is helpful as we try to make our programs, the best that they can be. And so even if it's hard to hear, it's not all positive, but we appreciate all feedback. So it really does help us in terms of thinking ahead to the next PFS and just any improvements we can make going forward with our program to make it accessible to everyone. So thank you, Jim.
Thank you. If there are any other comments, feedbacks, or questions, you can use the raise hand function at the bottom of your screen and we'll unmute your line, or you can place any questions in the Q&A box at the bottom of your screen.
I'd be interested to hear anything else that folks might want to add to the issue that Jim raised about how to better coordinate and collaborate with the SDPI programs and assure that we are improving access and the effectiveness of those programs. What other thoughts do others have about that, if any?
Again, if you'd like to share out, you can use the raise hand function and we can unmute your line.
So definitely, if anyone has any thoughts for improvements or any examples that you'd like to offer, feel free. This is a great time to do it. And we have extended this webinar until 4:30. So you have us here.
If there are any questions, I see we have Melissa has her hand raised. If we can unmute the line. Right, Melissa, you should be able to share. We can hear you.
Thank you, Dr. Mayer. This is Melissa Gower with Chickasaw Nation. I just echo what Jim talked about. I don't have any specific recommendations. I'd have to get with our diabetes person, but I do know that, when Medicare was developing their MDPP program, we provided lots and lots of input. IHS and tribes have been doing diabetes programs for 30 plus years. And it was just really frustrating at that time that our experience in providing those services to the American Indian Alaska Native population was not adhered to or implemented very well in my opinion. We've got to have providers that have billing sources, and we already had criteria and requirements in place and certifications, and then to go out and set up something different that required something opposite or more entailed than what we were doing for $7 a visit or something. It just didn't feel very good. So I really encourage you. I think the Tribal Leaders Diabetes Committee will be able to provide some really good feedback. It'd be nice if somehow we could get them to have the diabetes coordinators with IHS and tribes on a call. I don't know if that could be done through IHS Diabetes Division or not, but just to get the people on the ground that's doing the work would always be helpful also. So thank you for tackling this. Sorry, don't have any more specific items, but just wanted to provide those comments. Thank you.
Well, thank you for those for that input, and I hear your frustration, and it's certainly our hope and our intention to make sure that we are listening and that we are hearing you going forward. And I hear your suggestions about following up with the TLDC and in getting together both diabetes coordinators and IHS folks on the phone, and we will certainly pursue that. So thank you.
Thank you. If anyone else would like to do a share out to provide feedback, comments, or questions, you can use your raise hand function and we'll unmute your line, or you can place a question in the Q&A box. At this time, Beverly and Dr. Mayer, I'm not seeing any hands raised or any comments coming through.
Well, thank you, Michaela, and thanks again to everyone on the call for participating, and for those of you who shared your thoughts with us. And again, just want to invite anyone and everyone who might have additional comments after today's webinar to feel free to provide that feedback and input through the Tribal Affairs email, which is listed on the slide in front of you, or to me personally at my email, which is also on the slide. And look forward to hearing from you.
Thanks again, Dr. Mayer, and thanks, Michaela. And audience, we'll ask one more time if you have any questions on any of our presentations today. So we'll open up the questions for all panelists at this time. Again, one more time. Going once, going twice. You have us all here. So Michaela, do you see any questions?
Do not see any questions or hand raised at this time.
Wonderful, wonderful. So I would like to thank everyone. Thanks all presenters for taking time out today. I know it was a lot to coordinate so many people. Thanks so much for being able to hang out with us and provide these presentations. Always very helpful. And also thank you for those participants who had feedback and questions. That's always helpful for us to have that engagement as well. So with that said, I am just going to remind you that I'll remind you that a copy of the webinar will be found on our spotlight page, and that is on the American Indian and Alaska Native Outreach and Education website. Again, that is at go.cms.gov/AIAN. So again, that's go.cms.gov/AIAN under all tribes calls. And as always, you can always submit those inquiries to the Division of Tribal Affairs mailbox, as Dr. Mayer mentioned, And that mailbox can be found at tribalaffairs@cms.hhs.gov. So hope everyone has a great afternoon.
Thank you.
Thank you. Bye-bye.